Stop.
Okay. We apologize for the late start. Good afternoon and welcome to our emergency medicine grand rounds at the University Hospital of the West Indies, Mona campus. My name is Dr. Carlton Miller, third-year emergency medicine DM resident, and my co-moderator is
Dr. Jessica Roy, a second-year emergency medicine resident.
We want to specially welcome the following esteemed members of the audience: our head of department, Dr. Eric Williams, our program director and point of care ultrasound guru, Dr. Simone French, and our supervising consultant, Dr. Romaine Edwards. Welcome also to all consultants in our emergency department. To all our emergency medicine colleagues across the island, welcome. Our colleagues from the campuses in Bahamas, Barbados, and Trinidad and Tobago, we welcome you. And also to our colleagues in the wider Caribbean and internationally, joining us this afternoon, we extend a warm welcome to you all. Finally, to other specialties, medical professionals, and other members of the audience tuning in, thank you for joining us this evening. The management of cardiac arrest is an ever-evolving aspect of critical care medicine. We aspire to keep up with the curve in hopes that we give our patients their best chance at recovery. This afternoon, our topic is point of care ultrasound in cardiac resuscitation. We hope this grand rounds will prove to be interesting and informative. We have requested CMEs for this session. If you haven't already, please register using the link on the flyer to receive your CMEs. Please complete the pre-test provided in the chat and the post-test after the discussion. Thank you.
So at this time, I will invite Dr. Judine Frank, a second-year emergency medicine resident, to bring us a word of prayer before we begin. Dr. Frank?
Let us pray. Almighty Father, thank you for your blessings upon us. Lord, as we assemble this afternoon, we are grateful for the opportunity to have this session, Lord. We are grateful for the privilege to work together as a team, to share knowledge, and to strengthen our craft as we strive to be better physicians and as we strive to better serve humanity. Lord, I also ask that you will be with the organizers. Please sustain them as they continue to facilitate growth and development for the profession. Lord, I pray for the participants, and I also pray that your presence will abide with us and guide us so that whatever knowledge is imparted will be received well. Whatever I would have failed to ask of you, Lord, if it be your will, grant it unto us. I pray in your name, amen.
At this time, I want to welcome our first presenter, Dr. Jovel Victorin, a second-year emergency medicine resident. He hails from the beautiful island of St. Lucia and is a Spartan Health Science University graduate. He has special interest in pre-hospital emergency medicine and plans to return home to serve his country. Please welcome him as he goes through our case discussion.
Yeah, sure. It's good. Can you hear me? Okay. Hi. Hello, good day. My name is Dr. Victor, and I'll be guiding you through 3 cases today to demonstrate the critical applications of point-of-care ultrasound in cardiopulmonary resuscitation. So case number 1, patient name KC, 37-year-old male, presented complaining of shortness of breath for 1 day. He has a past medical history of hypertension, diabetes, and end-stage renal disease, and he's on hemodialysis twice a week. History of presenting complaint. The patient complained of sudden onset shortness of breath, chest pain, diaphoresis, and palpitation. Of note, he missed his last 2 dialysis sessions, most likely due to financial reasons, and he also stated that he's non-adherent to his fluid restrictions. So on physical exam, patient was seen in moderate to severe respiratory distress. He was diaphoretic, and his vital signs on presentation included a blood pressure of 192/120. Pulse was 109, respiratory rate 40. SpO2 was 90% on room air. Cardiovascular exam, he had normal S1, S2 with bilateral lower limb pitting edema. Respiratory exam, he had bilateral crepitations with dullness and percussion with intercostal retractions as well. So these were the pertinent physical exam findings. So we grabbed our point-of-care ultrasound device. So can you see my pointer? Yeah. Okay. So the first set of images, we have a still image to the left side of the screen of the right upper quadrant, and a looped video on the right side. So on the left side, you see this anechoic region above the diaphragm, indicating that the patient has a pleural effusion. And on the right side, this is a lung ultrasound showing B lines. Okay. So second set of images, we have still image of the IVC, which appears plethoric with minimal variability with respiration. And also you could see some slither of the pleural effusion on the right side of the screen as well, just above the diaphragm. So in summary, for physical exam findings, the lung findings, patient had crepitations and auscultations with bilateral B lines with pleural effusion as well. His IVC was plethoric, non-collapsible, and he had a bilateral lower limb edema. He was hypoxic and tachypnic as well. We did ISTAT investigations, which showed that he was hypokalemic at 6.6 with a urea of 37, creatinine of 1,768, and his blood HB was 7.5. Sorry. ECG showed that he had a sinus tachycardia with T-wave inversions and tented T-waves as well. ABG showed a pH of 7.16 and a bicarb of 20.3. ISTAT tropi was 0.04, which is the upper limit of normal. So that was the first trope taken for this patient. I included the central UNEs. So as you can see, he had the potassium of 7.4, no hemolysis seen, with a urea of 31.1, creatinine of 1,748 as well. So he was severely hyperkalemic. So the assessment was severe fluid overload with acute hypoxia, likely secondary to his missed dialysis sessions, hypokalemia and metabolic acidosis on the background of his ESRD, hypertension, and diabetes. So in regards to management of this patient, oxygen therapy was initiated to maintain his oxygen saturation above 94%. Hyperkalemia treatment was given 10 mL of 10% calcium gluconate, 50 mL of D50 with 5 units of soluble insulin. And we opted to do the 5 units of soluble insulin because of there's a study by Nicholas et al. In 2018, which showed that for treatment of hyperkalemia in ESRD patients, you could give lower doses of soluble insulin so to avoid hypoglycemic spells. We also gave him some Lasix to help diuresis him. He said he was able to pass some urine, and labs were done, including the UNEs and ABGs and troponin. He was also sent for a chest X-ray, and serial ECG monitoring was done. And for final disposition, the patient was referred to internal medicine for urgent hemodialysis. So during handover of the shift, the patient was observed to be in severe distress, exhibiting diaphoresis, and his oxygen saturation dropped to 80% on 10 liters or 15 liters of O2. So we intervened. We decided he was also a bit agitated. We examined him. He had bilateral wheezing, with crackles on his chest. So we intervened. We gave him Ventolin and normal saline nebs, and we also gave him ketamine to aid with his agitation. Despite these measures, the patient still became increasingly agitated, and the decision to intubate him was made after discussions with the seniors on the shift. So we intubated him. So I included a still image again of confirmation of our ET2 placement. I accidentally cropped off the image of the esophagus, but it would be on the right side of the trachea. But here you could see this rounded lumen with the ET tube in situ, with the posterior shadowing indicating air. So we had proper confirmation of our ET tube placement. So post-intubation, the patient was noted to be bradycardic with a heart rate of 30 beats per minute. We gave 1 milligram of IV atropine, and he subsequently arrested. We palpated for a pulse. There was no pulse. We did our point of care echo, which showed severe hypokinesia, eventually no warm motion at all, so akinesia. So we commenced CPR as per ACLS guidelines at 8:22 p.m. And we achieved ROS after 5 minutes of cardiopulmonary resuscitation. So after we palpated, we got ROS. We repeated our point of care ultrasound, and I included a video as well showing cardiac ultrasound in long axis. So you could see the patient has adequate warm motion, indicating with a rhythm on the cardiac monitor with a palpable pulse. So we were confident that we had return of spontaneous circulation. So for post-ROS care, we maintained him on O2 And we repeated his labs as well. Point of care potassium came back at 5.8, and his ABG, his repeat ABG came back at 7.27 with a bicarb of 24. And we sent him for urgent dialysis with close monitoring of his vital signs. We also got the repeat trope for him. So trope number 2 was 0.03, so no delta change. So likely his deterioration was secondary to his missed dialysis sessions. The repeat central UNEs showed that his potassium came right down to 4.7 with a urea of 13 from the 31 and a creatinine of 831 from the 1,700. So the outcome for this patient, he was stabilized post-dialysis, and he was admitted to the internal medicine service, and he was subsequently discharged 4 days later to follow up at nephrology clinic. So moving on to case number 2, we have a 73-year-old male by the name of DB. He came in complaining of difficulty breathing with a lot of secretions in the mouth on the morning of presentations. And as soon as he walked into our emergency department, he just collapsed. He has as per the relatives, he has a past medical history of hypertension, diabetes, and end-stage renal disease, and he's also on hemodialysis twice a week. He also has a history of prostate cancer. The relative stated that he was recently discharged from hospital after being treated for a catheter-related bloodstream infection and a subacute left basal ganglia infarct with aspiration pneumonia and severe anemia. And they said post-discharge, he was doing relatively well. His last dialysis sessions was 2 days prior. So on examination, the patient was noted to be unresponsive with no obvious secretions in his airway. He was warm to touch, and he had no palpable pulses and no visible signs of respiration. His glucometer reading was 12.2 millimoles per liter with a temperature of 36.8, and no other vital signs were recordable. We placed him on the cardiac monitor, and it showed a slow organized rhythm. So we decided to do a point of care cardiac ultrasound, point of care echo, and I included this image here. So you can see this swelling echogenic material in the left ventricle with basically no wall motion. So he had inadequate non-perfusing contractility. So we noted it as a true PEA, and we commenced CPR as per ACLS guidelines. After 2 cycles of CPR, we got an organized rhythm on the cardiac monitor. However, we had no pulse. So again, we repeated our point of care echo. And here you could see same echogenic material indicating blood just swirling around in the ventricle and poor wall motion. A bit better than the previous image. So we decided to continue our CPR. And then shortly after, the patient on our next rhythm check, he had a pulseless ventricular tachycardia, and we defibrillated him twice. Sorry. So at the rhythm check following the second defibrillation, we got a pulse. So we had return of spontaneous circulation. We repeated vitals for him. We got a blood pressure reading of 132/90 millimeters of mercury and a pulse of 101 beats per minute. And we repeated our point of care echo just to confirm that we had return of spontaneous circulation. So here, you can see good evidence of echocardiographic wall motion. You can see the valves moving. So just prior to intubating the patient, he again arrested, and we palpated for a pulse. We could not appreciate any pulse, but there was an organized rhythm on the cardiac monitor. So repeated the echo, and again we saw severe hypokinesia, some blood swirling around, minimal valve motion as well, but there was basically no effective contractions noted. So again, we recommenced our CPR, and we continued for about 20 minutes with no significant activity noted subsequently on interval ultrasounds. So we repeated our cardiac echo, and we also did the pulse check on the femoral vessels. So that was our echo. So here you could see cardiac standstill, just the blood swirling around in the ventricle, no wall motion, no cardiac wall motion. And here, this was an ultrasound done on the femoral vessels post cardiac standstill, and we have no evidence of pulsation or any flow in the vessels at all. So just for confirmation, we did one single chest compression just to confirm. So here you can see the femoral artery and femoral vein. With the one compression, you see this red flow. But otherwise, there was no flow in the vessels. So endpoint, we noted cardiac standstill on our ultrasound with no blood flow in the femoral vessels or no femoral artery pulsations. So, and patient had no visible signs of respiration. Pupils was also fixed and dilated, and hence we pronounced him dead. Case number 3, we have a 57-year-old female by the name of KL. She came in because of altered mental status. She had no known chronic illnesses. The relative said that she had a dry cough and decreased appetite for about 1 week, and decreased responsiveness was noted on the morning of presentation, denied any fever or chills. On appearance, the patient appeared ill, toxic looking. Her vital signs on presentation, temperature was 37 degrees Celsius. She was tachycardic at 129, respiratory rate was 24. Blood pressure was on the low side, 87/59. SpO2 was 81% on room air. GMR the glucose was 27.2. Her dipstick showed that she had glucose 3+ and ketones 4+. Primary assessment, airway was patent, no secretions was noted. Chest expansion was equal bilaterally. Trachea was central, breath sound decreased in the left lower zones with some crepitations heard. There was no rhonchi or wheezing. SpO2 was 95% on 15 liters of O2 on non-rebreather. The circulatory assessment, she had a low pulse volume, mucous membrane was pale and dry, so we initiated our resuscitation, placed 2 large bore IV accesses. CBC, extended UNE was done as well with LFT coagulation profile, group and cross match, and cultures were also done for her. So we bolus of 500 mils of lactated ringers, and it brought her blood pressures up to 106/60. So on abdominal exam, abdomen was soft, non-tender, no organomegaly was appreciated. She had front blood seen in her diaper. And on vaginal exam, it was erythematous and a friable introitus with blood seen in the vault, DRE, normal tone, brown stool. So here I included because of the hypertension, we did a point of care ultrasound, taking a look at her IVC. So as you can see, the walls of the IVC is basically kissing, indicating a severe hypovolemic state. And that was after the first 500 cc bolus. Also, you could see the collapsed bladder with the catheter in situ. So here you could see the balloon in the bladder. She had very little urine in the bladder. So in summary, the point of care ultrasound showed that she had a collapsed IVC, collapsed bladder, and a hyperdynamic cardiac contractility, no pericardial effusion or abdominal free fluid seen. So we continue to resuscitate her, give an extra 500 cc's of lactated ringers, and we included the repeat IVC, ultrasound of the IVC. So here you could see it's a lot better, good variability with respiration, but she was still hypertensive, blood pressure of 85/40. So we continued our primary assessment. GCS was 11/15. She had a left ptosis as well, but pupils was about 2 millimeters and reactive till light. So our ISTAT UNE showed that her potassium was 4.8, she was hyponatremic at 151, ionized calcium of 1.16, chloride of 116, lactate of 1.5, with a glucose of 28 and a bicarb of 6.6. Her VBG showed that she was acidotic at 6.89, and we calculated an anion gap at 28.4 with a osmolality of 330. So our assessment for this patient, we assessed her as having severe DKA/HHS with a community-acquired pneumonia with sepsis. We wanted to rule out a gynecological malignancy and sepsis-induced coagulopathy and symptomatic anemia and severe dehydration. We continue our resuscitation of this patient, continue giving her IV fluids to continue. We give an extra bolus and continue the infusion at 150 cc's per hour. We also commence insulin therapy as well. We gave her 2 grams of rocaphine and ordered CT brain and chest x-ray, and she was referred to the internal medicine and gynecological service. So whilst in the A&E department, the patient had a generalized tonic-clonic seizure lasting for approximately 1 minute, which was aborted with 5 milligrams of midazolam. And she was subsequently intubated because of her decreased mentation, and she was not able to maintain her oxygen saturation despite being on 15 liters of O2 via non-rebreather. We got her CT brain. We got a verbal report showing that she had some thrombosed vein of Galen and some lacunar infarcts as well, but there was no signs of any acute bleed or cerebral edema. Chest X-ray showed that she had some opacification in the left lower zone and right perihilar opacification as well. So her blood pressure continued to drop. The repeat was 71/40 despite continuous fluid resuscitation. So we opted to commence norepinephrine, starting at 10 mics per minute, and then we titrated up to 30 mics per minute, but she still remained hypotensive. So that patient was in severe septic shock. So she arrested 2 hours later. So we commenced CPR as per ACLS guidelines, and we achieved ROS after 8 minutes of CPR. So here we see the cardiac echo showing some good wall motion on the left-hand side. And that was the repeat abdominal ultrasound. So here we could still see the IVC, good variability with respiration. We did a lung ultrasound as well. We did both the left and right. So on the left side, on the left anterior chest wall, we could see some B lines here, which collaborates with our chest X-ray findings and our physical exam findings. So the patient again arrested 1 hour post return of spontaneous circulation, despite being bagged by the medical SHO and despite being on inotropic support. So we recommenced CPR for her, and we still had no pulse was palpated. Point of care ultrasound was done, which revealed poor cardiac contractility on the third pulse check. So here you could see there's no cardiac wall motion, so indicative of a cardiac standstill. So this was a true PEA. So we continued our CPR as per ACLS guidelines. So on the left-hand side, first sign of cardiac activity on the third pulse check. So we could see some wall motion contraction. Right on the right side, that was after our resuscitation attempts. So CPR was continued and we got ROS. ROS was achieved after 20 minutes. We had repeat vitals for her. Temperature was 35.7 with a pulse of 49, respiratory rate of 28. Blood pressure was 66/29 with an SpO2 of 94%. So we got ROS after the second arrest again, confirmed by our point of care ultrasound. And 45 minutes later, she arrested for the third time. We did an ultrasound confirming that she had cardiac standstill. After discussion with, well, prior to the third arrest, we had discussed with the relatives and we told them that prognosis was poor, and they agreed that if she arrested again, then we would terminate any subsequent attempts. So after the third arrest, we repeated our point of care echo. So here you could again see cardiac standstill, no wall motion at all. So that was on the long axis and here on the short axis. Okay, and that's it for me. Thank you.
Okay. At this time, we will facilitate some questions from the chat on YouTube. Question from Stephen A. is, at the time of acute deterioration, what was his electrical rhythm?
Sorry. So the patient had a PEA, so he had an organized rhythm, no pulse was felt, right? So that's for the first case. So he had a true PEA, and hence we initiated our cardiopulmonary resuscitation.
The second question from Yoli Gardner. What was the indication for administering atropine post-intubation? I know for the bradycardia, but atropine in post-intubation, what was the indication?
Well, it was for the bradycardia itself. So that was sorry. So the patient was noted to be bradycardic, and we made a decision to that was not after the, we did not give atropine after the intubation. So he was initially noted to be bradycardic. We gave the atropine and then he arrested. So we subsequently intubated him. That was for the first case.
All right. So we have a few other questions in the chat that we will facilitate during our question and answer segment. At this time, I will go ahead and introduce our speaker for our discussion. Hopefully, some of your questions will be answered during that time. Okay, so our discussion this afternoon will be done by our senior resident, Dr. Sasha Gay Miller Brizuela. She is known as Butterfly Brizuela because of her aptitude with the point of care ultrasound device, trademarked the butterfly. She's very good at the usage, I can tell you. She went to medical school in Cuba and was a teacher in her past life. She enjoys discussing interesting cases and life experiences with our resident group. And she is always ready to offer assistance to those in need. So please help me welcome Dr. Sasha Gay Miller Brizuela as we start our discussion this afternoon.
Thank you, Dr. Roy, for that introduction. I sound like a very nice person. Good evening, everyone. As she said, I'm Dr. Miller Brizuela. I'll be taking you through the discussion for this case today, or these cases, I should say. So our topic today, point of care ultrasound in cardiac resuscitation. Now, have you ever been in the emergency room or in the ICU or wherever it is that you work, and you have a little child who comes in for whatever reason, maybe a footballer who was playing sports, clutched his chest, fell to the floor and had a cardiac arrest, or a young 30 young male or female in their 30s or 40s who was a history of ESRD because they were hypertensive and didn't know and ended up with complications. Or a grandma who was so lovely, so kind, so pleasant at triage. She says, "Good morning, hi doc," or "Hi nurse, thank you for everything." You become attached to these patients, and then they have an arrest and you have to resuscitate. The decision as to when to stop, when to continue, it's usually a difficult one in cases like these when you grow so attached to your patients. So when there is an objective method of determining, are my efforts futile or should I keep going? I find that very useful. I find that very, let's say, I can go to my bed and sleep and know that I did my best instead of having that on my mind saying, should I have gone on a little further? That's how I see this. It's not new, but relatively new innovation of the use of ultrasound in cardiac arrest. So that's what we're going to be exploring today. The cases presented by my colleague are 3 isolated, distinct cases of patients who arrested in which we use the point of care ultrasound. We use the point of care ultrasound to determine possible causes of their arrest, and as well as to determine, should we be continuing, are we doing a good job, or should we, are our efforts futile at this point? So what is POCUS? I know we have people of different levels on this presentation. Some people are very avid with ultrasound, as we can see from the comments. Others are maybe novice to it. So we're using the term POCUS loosely, not to assume, we're not going to assume that everybody knows. So let's define the term POCUS. A POCUS is a portable ultrasound-based technology that allows clinicians to assess the patients at the bedside or in the field. Now, they call me Butterfly Brizuela because the one we happen to use is called a butterfly. Many of you have these devices in your hospitals because several hospitals in Jamaica were given butterfly devices by the Jaja Foundation. I'd like to extend thank you to them because it has opened up my world and I'm enjoying it. So what are the advantages of POCUS? POCUS is easily accessible, it's portable, it provides immediate feedback and delivers real-time insights. It's also radiation-free, so we don't have to worry about that. It's relatively low cost, and I say relatively because I know it's relatively low cost. Compared to a CT, for example, or another MRI, it's relatively low cost. It has higher sensitivity, but similar specificity to radiographs, for example, in the detection of pulmonary pathologies, right? So for example, a pleural effusion, a pneumothorax, it's more sensitive and similar in specificity. So why not use your ultrasound, right? It's also useful to guide procedures and it's excellent in the detection of pathologies in the pediatric population. Cardiac arrest, the topic of the day. What is cardiac arrest? This is referred to the cessation of mechanical cardiac activity as confirmed by the absence of circulation. And I emphasize mechanical cardiac activity because as we go through, we'll recognize that there may be electrical activity, such as in PEA or pulseless electrical activity, but there's no cardiac mechanical activity. So there's no pulse and there's no circulation, right? Cardiac arrest is fatal in 90% of cases, as per the American Heart Association statistics, with a survivability to discharge of 10.4%, and up to 8.4% may have good functional status upon this survival and discharge. with that high 90% failure rate, we need to try everything we can for our patients to get them into that small subset of persons who will survive. Cardiac resuscitations. We're not going to dwell today on, the aim of today is not to go through the ACLS guideline that has been established and we all follow through with same. We know the importance of high quality CPR and the different aspects of same or recommendations. We will not interfere with that. The point of this is to add to the ACLS guidelines. Not that we're adding it, we're not the ones discovering it, we're just, let's say we're joining in and trying to apply these recommendations, right? The next important thing about resuscitation that we must consider is early defibrillation, for example, of the shockable rhythms, and treat reversible causes of cardiac arrest according to the ACLS guideline. Now, this is the ACLS guideline. Today, we'll be focusing on the left, the arm on the left. So the non-shockable rhythm, which are asystole and PEA. Let me get my pointer. I hope you're seeing my pointer. Can you guys confirm that you're seeing a pointer? All right, so this arm, asystole and PEA, right? Okay. So according to the 2020 AHA, which is American Heart Association guidelines for cardiopulmonary resuscitation and emergency cardiovascular care, the use of adjuncts such as the ultrasound in CPR is considered a class of recommendation 2B, which is weak strength, and there is a benefit is great, is considered the benefit being greater than the risk, and it is reasonable to consider it. As it relates to the level of evidence, it's a level C, which is LD, sorry, which is limited data. They have done, means that they have done randomized or non-randomized observational studies, and basically it's not strong enough for it to be a class A or B, but as a class C, there needs to be more studies surrounding the topic. We appreciate that. We're helping them with their studies, hopefully. All right, so what is the importance of POCUS in cardiac arrest? So when conducted by trained individuals, and trained may mean a fellow in ultrasound, maybe a radiologist, but it also refers to us, emergency medicine physicians will receive some amount of training, because some studies have shown that even with 15 minutes of training with the use of a point of care, several the outcomes have been good in terms of detection, for example, of pulse rate. One study showed that. All right. So the use of POCUS, it helps to evaluate the quality of compressions. We can use it to identify the presence of cardiac activity, right? Also, it assists in detecting the reversible causes of arrest, the H's and T's as we know them according to ACLS guidelines, as well as we can use it to monitor interventions, and it's useful in prognostication of possible risk and survival, right? So with POCUS, we can visualize cardiac activity, which the objective of visualization of cardiac activity is defined by the visible movement of the myocardium. Stephen A. in the chat had asked earlier about the myocardium not moving, but the valves were moving. So objectively, it's a visualization of cardiac activity. So this excludes movements of blood within the cardiac chambers or the movement of an isolated valve, as we saw in the image shown by Dr. Victorine. So Dr. Stephen A. or Mr. Stephen A., that should answer your question, all right? So POCUS allows for the differential diagnosis, as I said, of different H's and T's, well, at least some of them, and we'll go through them throughout the presentation. What does the evidence show? Studies have shown that pulse checks are unreliable. Cardiac standstill is predictive of mortality, and it shows that there is a difference between pseudo PEA and true PEA, and we'll explore these. Data has demonstrated that pulse checks are inaccurate and difficult to palpate. It's difficult to palpate the pulses especially during an arrest due to a variety of reasons. It could include the patient's body habitus, the bearing techniques, the quality of pulse palpation differs amongst users. One study showed that pulse palpation in a pediatric cohort was only 78% accurate. Additionally, I've quoted 3 studies here, for example, that have assessed the reliability of pulse check. Salen et al. In a study including 38 patients, identified in 34 patients, no pulse was identified manually, but ultrasonographically, 11 of those patients actually had cardiac activity on ultrasound. Another study by Tibbles and Russell demonstrated that respiratory pulse palpation was only accurate in 78% this was a study in a pediatric population, ages from a few weeks up to 13 years. Ochoa et al. In another observational study of 72 healthcare workers demonstrated that 43% required more than 5 seconds to detect a carotid pulse. And this was in a healthy 34-year-old young male with normal blood pressure. And even so, only 43% required more than the 5 seconds, that we typically take in a resuscitation to detect a pulse. Imagine a person who has no pulse or a very weak pulse. Another randomized controlled trial of 111 healthcare workers who were trained for just 15 minutes to detect the carotid pulse using ultrasound. And then when tested, the first attempt at detection of a pulse was more successful in the focus group than the persons who did it manually. So even with minimal training, the ultrasound was more sensitive. The other information that we have, or what the studies have shown, is that cardiac standstill has a predictive value or high predictive value of mortality. The lack of cardiac activity on ultrasound in the setting of cardiac arrest indicates poor survival. Some studies have shown a mortality of up to 100% when cardiac standstill is detected during a pulse check. The largest trial to date is called the Reason trial. It included 793 patients who had PEA and asystole. In this study, 263 or 33% had cardiac activity on initial ultrasound, while 530 did not. ROSC was achieved in over 50% of cases where cardiac activity was detected by ultrasound. And on the contrary, others who did not have a cardiac activity had less success. Lack of cardiac activity on ultrasound was associated with non-survival, although 0.6% of these patients without cardiac activity had survival to hospital discharge, but that's a very small percent. So it is not exactly 100% sensitive for mortality, but so 0.6% survive, but it has a much lower success rate than if there is cardiac activity. Pseudo-PEA versus true PEA. Pseudo-PEA is defined as sonographic cardiac activity, but without a palpable pulse. And of course, there's associated cardiac rhythm. So it would not be PEA if there wasn't some form of organized rhythm on the cardiac monitor, right? Otherwise, if it's a flat, it would be asystole. Or it could be on the other arm, which would be VTAC or pulseless VTAC or VFib. So it is crucial for emergency medicine practitioners like myself and my colleagues here to distinguish this from PEA, because one, the treatment differs. As I said, there's limited data to support it, but there are recommendations as per the management of PEA, pseudo-PEA versus true PEA is different. So it's important to identify which one it is. Pseudo-PEA is associated with a higher rate of risk of ROSC, right? So return of spontaneous circulation and survival. Treatment strategies and prognosis differ between the two. For example, it is recommended that patients with pseudo-PEA, or one school of thought is that patients with pseudo-PEA is that you stop cardiac resuscitation, that instead of continuing CPR for these patients, it is considered that it's possible that this is as a result of a severe shock state that may be due to hypovolemia or sepsis. So recommendations include giving fluid boluses, giving adrenergic support. So we could start the patient, for example, on a norepinephrine drip. We could use, where it's recommended that you use epinephrine, pulse epinephrine, where instead of giving the 1 milligram IV Q 3 to 5 minutes as per ACLS guideline at this point in time, the 1 ampule of the epinephrine is placed instead in a 10 ml syringe made up with 9 mils of normal saline, and you can give 2 to 3 mils of that every 5 minutes until an infusion is set up, for example. But of course, as I said, this is not exactly in the ACLS guidelines, but anecdotally or from previous smaller studies, it's been shown that this is a recommendation, as there have been associated poorer outcomes with giving more than 3 doses of epinephrine 1 milligram, because there's an adrenergic myocardial damage associated with it. And from these small studies, they've seen improved or better outcomes in patients who are treated as such, as compared to continuing cardiac resuscitation in these patients who have pseudo PEA. So it's important to differentiate. Other terminologies that we use are PRES and PREM. PRES stands for pulseless with a rhythm with echocardiographic standstill, which is true PEA, and PREM, which is pulseless with a rhythm with echocardiographic motion, which is pseudo PEA. So those are other terminologies. As per these videos, which are from our cases, because we would not have you come here and spend 2 hours of your time for something you could Google, right? So we're showing you our images. Some will be from the cases presented and some may be from other cases, but images that we have taken ourselves. So this is considered true PEA because even there must have been a rhythm associated, for example, an organized rhythm. However, there isn't sufficient cardiac activity. Sorry, there is some cardiac activity, but there's no palpable pulse, right? So that's why it's considered pseudo PEA. And we know it was pseudo PEA because we had these patients, these are from our actual cases, and we knew these patients had no palpable pulse, had an organized rhythm, and we're seeing these images on the monitor. So the utility of POCUS in cardiac resuscitation. So POCUS, as I said, can assist in differentiating some of the H's and T's. It also differentiates pseudo PEA from PEA, but it also helps us to identify the correct rhythm, and as per ACLS protocol, we're able to follow same. What do I mean by this? Up to 35% of patients who presented in one study with asystole tend to have actual cardiac activity. Now, have you ever been in a resuscitation and you're not sure if it's an asystole you're seeing on the monitor or if it's a fine VFib? Well, POCUS can help with that. If you should examine this patient and see what was going on with the heart. If there's no activity, then yes, it's asystole. But if there's some fibrillator activities going on, it may just be fine VFib. And of course, the management would differ because now you would have to defibrillate that patient. And we know that patients with shockable rhythms do better in terms of resuscitation, CPR, and obtaining ROSC and survival than the patients with asystole or PE, particularly asystole. So that differs and that changes management completely. 2 large meta-analyses revealed pooled sensitivities of 77% and 95% and specificities of 80% and 92% respectively for ROSC as predicted by cardiac motion as seen on POCUS. Basically, when there's cardiac activity on POCUS, there's usually more likelihood of ROSC than if there isn't, as I'd said before. And as I mentioned, it helps us to identify the H's and T's. And just for refreshment, the 5 H's: hypovolemia, hypoxia, hydrogen ion stands for acidosis, hypo or hyperkalemia, or hypothermia. And the T's: toxins, tamponade, tension pneumothorax, and thrombosis, whether a myocardial infarction or a pulmonary embolism. Now, from this, POCUS can help us identify hypovolemia. For example, when Dr. Victor mentioned the case of and showed the image of the IVC that was collapsing for case 3, that's a sign that there's possible hypovolemia. a tamponade, for example, can be identified by ultrasound, and we go through that, as well as tension pneumothorax or a PE. So all 4 of those can be identified by using a POCUS, the point of care ultrasound. So what are the steps? I recall Dr. Elisa Paul Williams asking in the chat if we did the ultrasound first before we started arrest. No, we do not interrupt or interfere with ACLS guidelines. So first, if a patient is detected to not have a pulse or let's say patient is in cardiac arrest, we are going to start. The recommendation is to start CPR. Start CPR, you complete the first cycle, and if the ultrasound is available, then at the first pulse check, you use it to detect. You're going to first start with the cardiac window. So you're checking for what? You're checking for cardiac activity, as well as you're checking for possible H's and T's. Is there a cardiac tamponade that's causing patient to be in arrest, right? Is the patient having a pulmonary embolism, right? And we'll go through that. We also, and of course, within the rhythm check, you're still going to determine the rhythm because we're not interfering with ACLS. What is recommended is that you record a video clip during this check. So instead of trying to see while you have your ultrasound probe on the patient, what is going on, set it to record, place it to record, and then you take it off so you don't interrupt. Keep it between the 5 to 10 seconds that is recommended by ACLS. Once you have completed your checks, so you would have checked the rhythm, you would have checked for a pulse, and you've done your ultrasound simultaneously. So this, of course, is provided that you have enough hands, of course. Then you restart CPR as per ACLS. Then during the second CPR 2 minutes or 5 cycles, that's when you review recordings, analyze what is on your monitor, and then you can have a discussion with your team and make a joint decision. Do we proceed or do we stop based on what is going on, or as well as factoring where we are in the guidelines as per ACLS. So this is a protocol or sample protocol of how to approach use of point of care ultrasound in cardiac resuscitation. So first you prepare. So this is patient X arrest. Start CPR. While CPR is started, you're preparing your device. Of course, you're preparing the defibrillator. You put it on the monitors if the patient was not already on cardiac monitoring. So you're preparing, right? Now, once it's time for pulse check, that's when you do your recording. Then you resume CPR, review your images, and then you make a decision as to if there's something for you to intervene on. So for example, say when you did the cardiac window first, because that's where the recommendations are that you start. Say you did that and you recognize that there's a tamponade, then you would be preparing and setting up and proceeding with a pericardiocentesis, for example, right? If you detect that the patient, whatever pathology, you can intervene at this time, but you continue CPR as per ACLS based on what is going on with your patient. Another protocol or another guideline or another tool that we could use for the approach. This is an example. So it shows us here exactly what we do. So there's CPR going on, right? You've determined that there's a non-shockable rhythm. So the patient is in PEA or asystole. Of course, you do your 2 minutes of CPR, right? While you prepare, set up your ultrasound, you're going to determine which window you're going to use. And I'm going to show you the different windows. What is recommended is the subcostal or subxiphoid view, because that does not interfere with compressions based on where you have to put your probe just below the sternum, right? So you place your probe in that position, waiting for the time for the 30 compressions and the 2 breaths, right? So as soon as it is pulse check, or they say 2 minutes to start, then you're ready to go ahead and save your image. And what you can also do is on your device, press. So for example, the person is at 28, they're going to reach 30 shortly. You press record. So as soon as their hands are up, you can record your image, right? You've done that. So you start, the recommendations that you start at the apical window, but you can use the apical 4 chamber or the subxiphoid, because those don't interfere with compressions. And then once the time is up 5 to 10 seconds, you've done your pulse check, your rhythm check, you start your CPR again. Then you review your images, and then you make a decision based on that. So that's basically how we incorporate ultrasound in POCUS. In the presentation of the cases, if it wasn't clear, it's not necessarily that we're just doing POCUS right throughout and we're ignoring everything else. No, it's during the rhythm check, right? And as I was saying before, as it pertains to the windows, The first option is the subxiphoid view, and the apical four chambers is the second option because they do not intervene with compressions. During the pause for pulse, that's when you check. The other windows can be visualized during compression. So you can do your long views that should not interfere with compressions. You can do the apical four chambers or the parasternal short axis. The parasternal long is the last option because that definitely goes where the pans are placed for compression and we don't want to interfere, as well as the gel that is used for the ultrasound may interfere with the actual quality of CPR, which we don't want. So that's our last option, right? As it relates to cardiac windows. So this image shows us different places that we place our probes. Anybody who's familiar with ultrasound will know, but for example, if you don't, so here, these two blue are the anterior lung points. For example, we check for a pneumothorax, look for lung sliding. Here we could check for Morrison's pouch or the left upper quadrant, you're looking for free fluid in the abdomen. This green is highlighting a vascular exam because you can check for a DVT as well, because if there's a DVT and the patient has collapsed after having tachycardia, hypoxia, for example, could be considered a massive pulmonary embolism. So you can check for that using the blue protocol, for example, which we won't go into today. And then here first is where you do apical four chamber. That's where you put the probe, you realize this is the area for compression, so it would not be intervening. And this is the ideal. In your red here, the subxiphoid, because it definitely doesn't intervene and you're able to see the heart pretty clearly from there. And as I was saying, so these views, so this is the compression zone and the points are around it, so you shouldn't interfere, right? Parasternal, the parasternal lung is done right in this vicinity, so it would interfere with compressions, which is why it is the least recommended. So there are several protocols as to how to use POCUS in cardiac arrest. Some have been validated as well. We're going to go through a few, but they're quite, the first one and the more common one is the CASA protocol or CASA, which means cardiac arrest sonographic assessment. It is quite commonly used and it's evidence-based. It was introduced in 2018. It is used to quickly evaluate reversible causes of PEA. It's done within 10 seconds and it answers a question, basically yes and no between each CPR cycle. They recommend that you do one window per 10-second pulse check, right? So you're not going to be going from one area to the next in the 10 seconds or the 5 to 10 seconds. So first, you go in cardiac, as I said before, keep it less than 10 seconds because we don't want to interfere. You know, one of the qualities of high CPR is that we minimize pauses to less than 10 seconds, right? So is there? Yes. Then you go ahead and proceed with treatment, pericardiocentesis, for example. Is there, if not, is there evidence of right heart strain? And we'll stop a little on this one. It is recommended that you check for right heart strain with your first pulse check, with the ultrasound that is, because it may, in this case, be associated with pulmonary embolism, a massive pulmonary embolism, that is a massive PE. But subsequent to that, it is not very sensitive because compressions are known to equalize basically the pressures in the chambers. So after that, you may see right heart strain, but you cannot attribute it definitively to a PE in that case. So it is recommended that you do check for this with your first pulse check, right? And the next question, of course, is there cardiac activity? So is it PEA or is it pseudo PEA? And then the other, it also entails the long views as well as fast, but these do not interrupt CPR, so they can be done during compressions. So that's the CASA protocol. There is also the POCUS-CA, which is the point of care ultrasound in cardiorespiratory arrest. It also looks at the cardiac windows, the lung windows, the abdominal views that we're looking at. For example, does the patient have a leaking or ruptured AAA and is there free fluid in the abdomen, right? Is the patient, and they also assess for DVTs, checking femoral or popliteal as well. Definitely doesn't interfere with CPR. So this would correlate with the patient having a pulmonary embolism. Now, the cause protocol checks the cardiac as well as the lung views for the same things. And just to mention, with cardiac, is not just tamponade, you can check for hypovolemia because it includes, if there is a collapse of the left ventricle upon systole, for example, that would suggest that there is some hypovolemia, right? Now, I'm not going to go through the entirety, but just showing you that there are several protocols set up since 2007, going as far up to 2020. Right? One of the common ones is the Sesame protocol, sequential echocardiographic scanning assessing mechanism or origin of severe shock of distinct cause. A big mouthful. So Sesame trial or Sesame protocol that was developed in 2015 by Dr. Lichtenstein himself. Right? So it's just a sequence of windows to detect the cause of arrest. So first they check for pneumothorax, second for a diagnosis of pulmonary embolism using the blue, and include the blue protocol there. The third, you're gonna check for signs of hypovolemia, and it continues to as far as a DVT examination. And that's not just, these are included, but there are several. So the last one was that we have here is up to 2020 and is the easy ALS protocol. The initial protocols just involve the cardiac windows, but as they progress, they start to involve cardiac and lung, and then abdominal and vascular started being included later on. So there have been extensive studies and protocols developed using the POCUS. It's not new, but relatively new to us, but it's not new. So what are some of the utilizations of POCUS? We have been mentioning cardiac tamponade so many times. So in non-cardiac arrest patients with pericardial effusion, findings suggestive of cardiac tamponade include diastolic right ventricular collapse, which is 48 to 60% sensitive and 75 to 90% specific. So this is basically seen during diastole, there's a collapse of the right ventricle, basically, with an associated pericardial effusion, of course. Also, the systolic right atrial collapse is also 50 to 100% sensitive and 33 to 100% specific. The lack of right-sided chamber collapse carries up to 90% negative predictive value for tamponade. So you're not seeing that there's a 90% chance that it's not there, right? So ultrasound is quite sensitive in detecting cardiac tamponade. One large multicenter study showed that the use of transthoracic echocardiography in cardiac arrest was found to detect tamponade in up to 4% of cases. Patients who underwent pericardiocentesis for this tamponade demonstrated a higher survival to discharge than other patients, which we're talking about 15% compared to 1%. Therefore, when a pericardial effusion is identified and there is heightened suspicion of tamponade, then of course, emergency pericardiocentesis should be performed. I've included here, this was actually a video of a traumatic tamponade. So if the video would play, you would notice that this was actually during the process of the pericardiocentesis. You would can actually see the needle, but I'm having a little technical difficulties. Okay, so I'll just improvise. So this is the heart. It was moving, which is why it looks so shaky. And this is fluid in the pericardium. So there's a pericardial effusion here. It was significant enough. I was there. Patient went into tamponade and we did pericardiocentesis, took off, I think, 80 mils of blood, and patient was rushed to operating theater and did survive. So this one was peri-arrest, didn't arrest. And POCUS is also useful in detection, as I said before, of massive pulmonary embolism. The evidence indicates that PE may be the cause in 2 to 5% of cardiac arrest. What are some of the signs? You could have right ventricular dilatation, an increased RV to LV ratio, so greater than 1. The normal is 0.6 to 1. So the right ventricle is supposed to be smaller than the left ventricle. When you see them equalizing or the right ventricle being bigger, then there's something going on, right? There's possibly a massive pulmonary embolism. Another sign is a McConnell sign. McConnell sign is a hypodynamic right ventricular or free ventricular wall with sparing of the apex. I'm going to show you some examples. And then also the D sign, or you might see a thrombus in situ. So you have indirect signs, for example, which would be the RV dilatation, or the D sign, which would be the shape of the LV taking on the appearance of a D, a capital D, as there is bowing of the septum. And then we have indirect signs, for example, as the McConnell signs. I'm going to show you videos of them. Okay, they're playing this time, thank God. So Here, this is an image of a patient that had CTEPH, chronic thromboembolic. This patient had multiple PEs before. And this is not the best window, I must say. This is not the window we use a short axis, a personal short axis normally to see the D side. It's just that this patient was so significant in terms of the pulmonary hypertension it could show on this image. This is the right ventricle here. The right ventricle is always closest to the probe marker, which is this blue thing here. So look comparatively the size of the right ventricle to the left ventricle. This is the septum. As you see, it is being, we call it bowing of the septum, or it is being deviated towards the left ventricle, so much so that it gives it a D shape. But as I said, this is not the view for that, but I wanted to show you how, or something that you could see in a patient with a massive PE. And on the right, this is the right ventricle here. As you can see, it is more prominent than the left ventricle. This is also a possible pulmonary embolism. Of course, there are other causes of RV strain, but just we're on the topic of PE today. Another one, the McConnell sign, as I mentioned, so if you're seeing my pointer, you can see right at this is the apex. So this is an apical four-chamber view. This right here is the right ventricle. Over here, we have the left ventricle. This is a septum. As you can see, both chambers appear to be of similar sizes. So the RV to LV ratio is off, right? So it's increased. Also, what I wanted to show you was the McConnell sign. You see this area, if you can see clearly, there's a dipping, or we call it trampoline. So this is due to the hyperdynamic apex. So the apex is moving quite quickly as compared to the free wall, which is not doing much. So you get this McConnell sign. It is not very sensitive, meaning you don't see it a lot, but it's very specific for pulmonary embolism. So when you see it, it's very likely that the patient has a pulmonary embolism. This was an image done by a patient, an 84-year-old female that presented with tachycardia, shortness of breath. And this was our ultrasound. We were at a type C facility. We didn't have CT available immediately, but from this ultrasound, I was able to diagnose and treat PE within half an hour. One patient, grandma, walked home a few days later. The CT was obtained like 4 days later and confirmed the PE. So ultrasound is very, very helpful. Ventricular fibrillation. As I mentioned before, ultrasound may assist in determining, is it asystole or is it fine VFib? And as I mentioned, VFib, once you treat it appropriately, has a better outcome than an asystole. So this is a one utility of POCUS, right? The management is different because you cannot treat it the same as an asystole. You need to defibrillate this patient, and their survival rate is improved with treatment. POCUS can be used to determine hypovolemia. The size of the LV, or the left ventricle, can be assessed, right? The left ventricle may be hyperdynamic with obliteration of the left ventricular volume at the end of systole. And we can also look at the IVC, because a flat IVC, for example, so normal IVC is 1.5 to 2.5 centimeters, but anything less than 9 millimeters is considered a flat vena cava, and likely the patient is hypovolemic and would respond to fluid therapy. Please note that you must consider the interpretation of IVC measurements in the context of hypovolemia in cardiac arrest, because there may be venous congestion during CPR that can limit the significance of the IVC. Other things that may affect the IVC could be the use of mechanical ventilation, individual patient characteristics, as well as concurrent medical conditions may influence the size and collapsibility of the IVC. So it's not as straightforward in cardiac arrest, right? So for example, our patient in case 3, where the IVC appeared distended, it could be that the patient had been resuscitated adequately with fluid, but the patient was also receiving positive pressure ventilation that could have influenced the IVC. So you have to interpret it in the context of the patient. And just so that we're learning and applying what we're learning, these are just some images to compare. Mind you, the probe is turned opposite way on this one. And I remember somebody asking in the group, how do we know it's the IVC? You're not seeing the right atrium. Well, here would be the right atrium, and this would be IVC. This is a plethoric, and I'm on the right. This is a plethoric IVC. Normally, there's some variation respiration. With this patient, there is minimal variation and the IVC is barely moving. Variation meaning it should be getting smaller and larger with respiration, like you're seeing on the left. But this one is, we call it a kissing IVC. So you're not, in this case, this is where the right atrium should be, or it is, but it's not, you're not seeing it fully, as the person commented. But you realize during respiration, this is kissing. It should not be making that much contact. So this patient was in fact hypovolemic. As compared to this patient, it was either overloaded with fluids, that's one differential, or they're having an obstructive shock picture, so they could have a massive pulmonary embolism, or they could be having a tension pneumothorax, for example. But something is causing this tension of the IVC. As Dr. Victor mentioned, we can use the ultrasound to determine the tube placement. So a part of ACLS is to ensure that the airway is adequately protected. And also a part of post-ROSC management is airway protection and intubation. Now, in a busy ED and with everything going on, sometimes on patient with difficult airways, you may not be sure if you've intubated properly, but also even if you are sure, it doesn't hurt to be a little more sure, because esophageal intubation is not exactly ideal. That's not what we want, and it comes with its set of complications. So we can use our ultrasound to quickly, without interrupting compressions or anything else, we can use our probe to detect whether the ET tube is placed properly. In the setting of arrest, so we have alternatives of checking, for example, if their ET tube is placed correctly. We know this. 5-point auscultation, the waveform capnography, end-tidal capnography. But this is less accurate in cardiac arrest because there may be low cardiac output, which naturally there is going to be given that the patient is arrested. There may be reduced pulmonary blood flow, as well as administration of peripheral vasopressors may affect the end-tidal capnography, but ultrasound is objective. It's either there is or is not there. Also, low or absent end-tidal CO2 could signal that there's esophageal intubation, but it may also indicate poor circulation due to the cardiac arrest that the patient is having, or let's not say inappropriate, but chest compressions, for example, that they're not ideal, they're not adequate. Or there's a prolonged arrest time, there's hypothermia, there's a substantial ventilation perfusion mismatch. So all of those can affect the EtCO2. So POCUS is 99% sensitive and 97% specific for confirming endotracheal tube intubation. So I like those odds, right? So I'm going to show you an example of what it should look like. This is the image from our patient 1 from case 1, Dr. Victor went through. This is called the double lumen sign, and you realize you have, so 1 and 2, this is saying that the patient was correctly intubated by Dr. Victor and his team, as compared to on the right, where you're seeing now what they call a double track tube. So the esophagus is here. It's here on Dr. Victorine's patient, but you're not seeing it so prominently because the ET tube is not there. It's where it's supposed to be. But in this patient, it's highlighted because this is an esophageal intubation. And yes, this one came from the internet, not from us. Okay, let's clarify that. All right, as it relates to pneumothorax, POCUS is 91% sensitive and 99% specific for identifying pneumothorax in a supine patient. It can also be used to determine the depth of pleural interface to ensure that the needle is, for example, if you're doing a procedure, it can guide the procedure in terms of correcting tension pneumothorax. But we don't have time for that technical in the A&E, but it's a possible use, right? But it's very specific. And what we look for is lung sliding. Now, we use the anterior lung views that I had shown you earlier, which is between the 4th and 5th intercostal space in the mid-clavicular line. And so these lines, so this and this here, these dark areas or anechoic images are the ribs. This white line between, that's shimmering, that's the pleura. So this image is not of a pneumothorax. This is of our patient showing that there's adequate lung sliding because you're seeing the shimmering. If there was a pneumothorax, you would not be seeing this movement and shimmering, right? So I'm just showing you what is normal here. In the presence of a pneumothorax, there would be no shimmering, or there would be a shimmering of part of it and the other part is not, and that's what you call a lung point, which is also a very, very, very specific sign and the most ideal or the most specific and criteria to determine a pneumothorax. You can also, in the M mode, I don't have an image here, but in the M mode, you can see a stratosphere barcode sign that would also confirm a pulmonary, a pneumothorax, sorry, on ultrasound. The ultrasound can also be used to determine if there's an intra-abdominal pathology, right? So in a young female of childbearing age, amongst the differential, we consider a ruptured ectopic pregnancy. We know how fatal that can be if it is not treated appropriately. So say a patient who was arrested, that age group, and we find free fluid, one of the differential would be that the patient has an ectopic pregnancy. And of course, you can confirm that right then and there with ultrasound. And if ROSC is obtained, then we can institute appropriate management. It can also evaluate for other causes of free fluid, such as ruptured AAA, abdominal aortic aneurysm, or an aortic dissection can be confirmed from ultrasound as well. And these will not interrupt your CPR, as well as trauma. These images are of another patient that I had at some point in time, showing free fluid in the abdomen. This is a right upper quadrant view. This is the liver here. The kidney comes into play right here. In between, you have the Morrison's pouch, but here you're seeing free fluid here. And this is the left upper quadrant. This is the spleen, and then the kidneys should be here where you're seeing this white area. And then this anechoic or dark area is free fluid. So just to show you what free fluid may look like in the abdomen. All right, another use of focus in cardiac resuscitation is to check for the pulse. As I said, the reliability of manual pulse check is very low. So we can identify the pulse using the ultrasound because pulse may be weak or it may be inconsistent. There may be variations based on the individual's body habitus, for example, so it's not easy to find a pulse. Have you ever been in a resus and somebody said, I feel a pulse, and another person saying, I don't feel it, and you're so unsure, so you just continue CPR? How about using your ultrasound? You can use it on the femoral, or you can use it on the carotid, and the carotid artery to detect whether or not there's a pulse, right? So you know that, is there ROSC or is there not ROSC? All right, so just to show you, 1 second. Right, so in comparison, so the use of cardiac ultrasonography allows for faster and more precise pulse detection compared to manual analysis and Doppler sonography. To shorten the time for assessment, we recommend locating the carotid or femoral arteries prior to the pulse check. Remember, we're trying to keep the pulse check between 5 and 10 seconds, no more than that. Evidence suggests that this technique is feasible, accurate, reliable, and quickly performed, and easily learned by emergency physicians. So I'm going to show you now what a normal pulse check would look like compared to what our patient, we had an image in our previous case, I think case 3. So this was of a patient, patient was not normal, it was an ill patient, but he had a pulse. So this was the femoral pulse of this patient. And we realized this is a pulse wave, the arterial pulse wave, showing that there's normal pulsation. We couldn't get a video for this on the butterfly, but this is the image we got. And this image on the right represents is a Doppler ultrasound where you can see adequate flow through the vessels as compared to our patient. So red and blue does not necessarily mean arterial versus venous. It just means towards the probe or away from the probe, but it shows that there's adequate flow there. As compared to our patient 3, where this, as from this box that you're seeing here, as well as these red and blue highlights here, shows that it's in color flow Doppler mode, but you're not seeing any flow. Dr. Victorine had shown you where we actually did a compression to see what happens, and then you actually saw some flow, but this was a patient that is post-arrest and post-cardiac standstill and was pronounced dead, right? So there's no pulsation and you're not seeing any flow as well. So that's another use of POCUS. Other applications of POCUS, it can be used to identify the appropriateness of chest compressions. Proper compression is pivotal to cardiac arrest management, with it being correlated with ROSC and survival. Cardiac administration generates a blood flow that is 20 to 30% of normal cardiac output, but should still produce a palpable pulse. Nonetheless, the hands are commonly placed in a position where the area of maximum compression is the aorta in most patients. The literature reports that improper hand position during resuscitation may lead to compression of the ascending aorta, the aortic roots, or outflow tract of the left ventricle. POCUS facilitates adjustments being made to the applied forces and the location of the hands to optimize compression. Now, this is ideally with a transesophageal echocardiography, because of course, it's difficult to see when you're doing chest compressions and trying to do transthoracic. So this is more ideal for using the TEE as compared to TTE. Other applications of the ultrasound, you can use ultrasound-guided intravenous accesses. It's already difficult to find the access to insert an IV access in some patients when they're alive, imagine during arrest. But you can use your ultrasound to assist with this to site an IV access so we can give the epinephrine that the patient requires. Also, another utility is a transcranial Doppler ultrasound, for example, in the pediatric population. So you can assess cerebral blood flow using a point of care ultrasound as well. The ultrasound is also useful for prognosis. As we've mentioned before, when there's cardiac activity on initial ultrasound, there's a higher likelihood of ROSC, right? It helps with the decision-making in terms of continuity of efforts during CPR. I'll say, for example, case 3. During case 3, that patient was the mother of a colleague, it was a doctor's mother, who during the second cardiac arrest, I recall the internal medicine doctor as well. It was a patient admitted to internal medicine, but was in the emergency department, so we were assisting with resuscitation. But I recall the daughter saying, do everything you can. And this is the second arrest, and we were 15 minutes into the arrest. How do you know that you continue? How do you know that you've done your best? But we were seeing cardiac activity, so we were like, continue. Another thing that this case taught me in terms of use of point of care ultrasound in arrest was the quality of CPR. So initially the patient was being ventilated by an intern who was doing CPR, but when it was done by another more experienced physician, there was a different outcome. So the quality of CPR was shown, as well as the use of point of care ultrasound, because we were seeing activity on the ultrasound. We said, okay, continue, there's a chance. It wasn't strong activity, but there was activity. So there was signs that there was possibility of ROSC. And we continued, and upon 20 minutes of CPR, we did get ROSC. Mind you, the outcome in the end wasn't good, but it did lead to a second ROSC in this patient. So it helped us in the decision-making as to whether to continue or not, right? And the cardiac contractility on initial ultrasound also is associated with greater survival chances at discharge. So as the reasons that I mentioned before show that in 33% of patients who presented with non-shockable rhythm, there was improved ROSC, improved survival to hospital admission, and improved survival to hospital discharge. And on the contrary, when there's no cardiac activity, the survival rate is extremely low. In some studies, it's 0%. And there was ROSC in over 50% on the other hand of patients who had activity in one study. Another application or prognostic application in traumatic arrest, for example, there's a 2021 meta-analysis that reported that cardiac standstill in traumatic arrest was 91% sensitive and 98% specific for failing to achieve ROSC. Of note, no patient in that particular study had with cardiac standstill in traumatic arrest survived to discharge. So asystole is bad in trauma, basically. Another meta-analysis in atraumatic non-shockable cardiac arrest, so PE or asystole, reported that cardiac standstill was 92% sensitive and 60% specific for failing to achieve ROSC. And while cardiac activity on POCUS had an odds ratio of 10.3 for survival compared to 8, and 8 for survival to discharge. So their odds are a little better. Now, we're here talking about the good things about POCUS, or the potentially good things, but in everything, there are ups and downs. So we do have some pitfalls, and we're going to highlight them today. Pitfalls to the use of POCUS in cardiac resuscitation. So one, it can be a general pitfall. It can be related to the device, whether it's transthoracic or if it's esophageal echocardiography. So as it relates to general pitfalls, one would be that it has been shown in several studies that it may increase the duration of pauses during chest compressions. One prospective study, cohort study with 24 patients, where they're assessing the use of POCUS and CPR, and POCUS during CPR, it showed that there were longer pauses, median pause of 17 seconds in the patients who did not, 17 seconds with the use of POCUS and 11 seconds without, which is like a 5 seconds difference, which is significant in one study. Another study showed a difference of 8.4 seconds. So it can be, if it is that we don't apply appropriate protocols and stick to the ACLS guidelines, it can delay the pauses, which is not good during CPR. So we don't want pauses more than 10 seconds. So longer pauses have been observed to lead to worse outcomes, while shorter pauses are more favorable. Longer pauses were noted, for example, if the ACLS leader is doing the ultrasound themselves. So it's ideal to have another person who is doing it. Shorter pauses, of course, is going to be seen with a more trained hand. So when the trained fellows, ultrasound fellows, did the ultrasound in one study compared to the untrained, of course, the pauses are longer. So those are things to factor in. So you use the most experienced person, for example, or you use a second individual different from the person who is either doing the CPR or leading the team. In a single center prospective study of 23 patients with cardiopulmonary arrest, the use of POCUS was associated with significantly increased duration of pulse check by 8.4 seconds. And this adversely affects the outcomes of high quality compressions. So because these pitfalls have been noticed, there have been strategies devised to minimize these pauses. So when you're instituting, so when you leave here today, having learned and having seen that POCUS can be used in cardiac resuscitation, you're going to implement this in your setting, or if you've already been doing it, but you see you've learned a few more things today, I would hope, then you're going to try to apply these strategies to minimize the interruption. So one, with the point of care ultrasound like the butterfly, it's just one probe, but if you're using a larger device, using the phase array probe is noted to be preferred, because it's the one that's used for the cardiac, we call the cardiac probe, that is, because it has a smaller footprint, so it better visualizes the heart through the subxiphoid and parasternal long axis windows. Another method, it would be using the most experienced sonographer to perform the scan, using transesophageal echo as compared to transthoracic if you have the device, or if the training is available. Because of course, because it's not placed on the thorax, it's transesophageal, then it doesn't interrupt compression. So it's more ideal, but it's not as readily available. And as we mentioned before, if you have a second hand to do the ultrasound as compared to the person performing the CPR or the person leading it, so there's no distraction. There are other methods. So for example, the other views that I mentioned, the lung, the airway, abdomen, they can be done while compressions are going on. So we don't interrupt compressions for that. Using the optimal cardiac window, which is the subxiphoid view, or the apical 4-chamber views. Press record before and record the image during the pause, and then you review it later as compared to doing it simultaneously while you're waiting and wasting time looking at the images. You perform another suggestion is to perform one sonographic window per pulse check, and consider a protocol. As I mentioned, I listed about 10. Choose one or choose 2 or 3 and familiarize yourself with them so you can use them. For example, the CASA protocol. If you're going to do a transpersonal long axis view, for example, keep a towel nearby so you can wipe off the gel immediately so that it doesn't interrupt the quality of CPR by the person performing the chest compressions. And you can also have a designated person counting down the 10 seconds so that we don't lose track of time and pass the time that is recommended. So pitfalls relating to the transthoracic echocardiography, as I mentioned, because the probe placement may interrupt chest compression. The gel themselves the gel itself may interrupt compression, as well as the image quality may be affected by body habitus. The second patient's images were very clear because this was a slender gentleman. So it was easier to see his images as compared to another more obese patient. And the transthoracic does not evaluate the quality of chest compression as well as the transesophageal. However, the transesophageal is quite invasive and quite expensive, requires further training, and it cannot be used for like deep venous system assessment. So everything has their ups and downs. So we're at the end. So in summary, POCUS is highly versatile. It has various uses in cardiac resuscitation. It is important to use a proper technique to minimize delays in chest compressions. And in appropriately trained hands, POCUS can be integrated into cardiac arrest care and used to provide more targeted management for resuscitation in critically ill patients. I do trust that you've learned something today, and these are our references, and we thank you very much for your time.
Okay. Hi, I'm Dr. Roy. I'm back. At this time, we would ideally have our question and answer segment, but I am informed by my technical team that questions have been addressed in the chat. I hope that everybody is satisfied with the answers, but if you have further questions, please post them in the chat. Also, just a reminder that we do have a post-test for all participants, and you need to complete same to get your CMEs. So at this time, we'll be giving you 2 minutes just to complete the post-test in the chat while I invite back my co-moderator, Dr. Carlton Miller, to bring us the vote of thanks.
On behalf of the University Hospital of the West Indies, Emergency Medicine Division, we would like to express gratitude to you all for tuning in. We have come to the end of this informative academic session, which I'm sure stimulated the imagination regarding the future of cardiac arrest resuscitation. I would like to highlight my co-moderator, Dr. Roy, for what seems to be a natural talent demonstrated today in conducting the proceedings. I've been taking notes. To Dr. Judine Frank, your prayer was warm and an appropriate opening to the evening. Thank you. Our presenters made us proud. Thank you, Dr. Gerval Victorine, for clearly illustrating those clinical scenarios and for advocating that we pursue this topic. Dr. Sasha Gay Miller-Brizuela, the discussion was well delivered, quite edifying, and your delivery commanded our attention. Special thanks to Dr. Sujay Gore, fourth-year resident, for turning the cogs behind the curtains. Your invaluable contributions, including but not limited to the flyer design, registration organization, and team leadership, ensure the success of today's proceedings. We extend sincere gratitude to Dr. Errol Williamson for his technical support, which saved us when we couldn't figure out how to get the YouTube link to work. A big thank you to the other members of the team, Dr. Matthew Blackwood and Dr. Monique Pusey, who were utility players through and through. Their contributions are layered into every aspect of today's event. Dr. Romaine Edwards, our coordinator, thank you is not enough. You say jump, we say how high, and everything works out. Dr. Simone French, our clinical coordinator, we can only hope that this presentation serves as testimony regarding our appreciation for your work in integrating point-of-care ultrasound into our training. Big thanks again to the head of the Emergency Medicine Division, Dr. Eric Williams, and the other consultants for your continued stewardship. Finally, to you, our audience, thank you for participating in today's proceedings. Without you, it could not have been a success. Thanks again and have a good evening.
Okay, I am just double checking that we have all completed post-test. A separate link has just been placed in the chat for the post-test. So please go ahead and try that second link for the post-test. All right, thank you so much for joining us and enjoy the rest of your evening. Goodbye.